So good morning, everyone. Welcome to the Tele Trauma Grand Rounds. Today we have Dr. Niazi presenting, who is the Medical Director, Surgical Neuro-Oncology at the Nicholas Children's Hospital. It's an absolute pleasure to have you with us and present the case. I'm looking forward to learning a lot from this. So over to you, Ma, to start the presentation.
Thank you so much. Thank you to everybody for joining. It's really a privilege to be able to be here and present to you guys this morning. So I was going to discuss neurosurgical emergencies and management and through one case. And really, it's a pediatric neurosurgical emergency, but it does have some similarities to how we would be treating adult patients as well. Okay, so I have no disclosures. And so this is the clinical case. This is a 14-year-old female who was involved in a parasailing accident. She was essentially the wind picked up and the parasail let loose from the boat and it slammed against a bridge. She was found unconscious in the ocean, but with a life vest on and breathing. The local Coast Guard scooped her up and she was life flighted to us. No medications en route, only oxygen. And via nasal cannula and an IV was started. On arrival, she wasn't intubated, but she had laborious breathing. Her heart rate was 56, blood pressure 155/90, satting 89% on 2 liters nasal cannula. On exam, she had no spontaneous eye opening. Her pupils were 8 millimeters and fixed bilaterally with no movement to stimulation. She was flaccid and intermittently moaning, and she had a large hematoma overlying the parietal region. Okay, so the next steps. First, as she arrived at our emergency room, our trauma room, we proceeded ahead with the airway and we proceeded ahead with intubating her. They placed large bore IVs to stabilize her a bit. Abdominal fast was done, given the mechanism of injury, which was negative. And then a CT scan of the brain and spine were performed. All right, and this is her CT of the brain. The CT of the brain on the right side or the left side of the screen demonstrates an axial non-contrasted head CT with a large right-sided subdural hematoma with associated midline shift and loss of the gray-white interface. And there's no associated fracture, so I didn't show us bone windows. So large hematoma. And then this is a good depiction of her midline shift. She had about approximately 1.3 centimeters of midline shift with approximately 1 centimeter sided acute subdural hematoma. That right side of the brain is very dusky and dark. And again, she was down for an unknown period of time until the Coast Guard was able to locate her and find her. So I guess, do we open this up to the panel now, or how would you like to proceed ahead?
Sure, we can
Okay.
open it up to the panel now.
Perfect.
Dr. Kasim, would you like to make your comments first?
So I was wondering, how this should have been managed initially. I guess the Coast Guard is not attuned to resuscitation and definitive treatment in patients like this. I think the two things that I have learned listening to other doctors who practice neurosurgery is that hypoxia and hypertension with bradycardia, those are bad signs following some type of a head injury. And so you need to correct the hypoxia, and then you need to also stabilize the blood pressure somehow to a level they say should be somewhere around 120. So now you have this patient admitted to a tertiary care center, of course, the first thing you would do would be airway. And how you manage the airway is also very important, I was told. What medication to use, how you go about getting the intubation done safely in a situation like this so you get the maximum benefit. And because patients like this, apparently, if you overstimulate, they started convulsing, throwing up, and that increases the intracranial pressure as well. So I would be interested in knowing what medication did they use to intubate this patient and how was it done, especially in a pediatric age group, which is, I'm told it is different from adults somewhat. Not categorically, but there is a difference.
No, you're absolutely right.
Those are the things that I'm thinking. Again, my knowledge on neurosurgery is very limited. I'm just telling you what I've heard from my colleagues.
No, you're spot on. Everything that you just said was absolutely correct. So we'll go back to this picture. So where she came in and she did have essentially Cushing's triad. She was bradycardic and hypertensive, and she absolutely should have been intubated in the field. Unfortunately, they did not. It was the closest team that was able to pick her up and scoop her up and bring her to us. So not ideal. There's also a search, and the Coast Guard put up a search for her. So you're absolutely right. In an ideal setting, the airway would be managed, she would be intubated, and IVs would be started. The intubation here was done with vecuronium and propofol, which is usually not something that we use in pediatrics, but that's what was used in the emergency room for her. I think that the propofol was used mainly to bring her blood pressure down. And the other big thing here is we don't want to hyperventilate these children, and I'll touch base on that a little bit later in this talk about avoiding secondary injury in relation to cerebral perfusion and cerebral blood flow. So with her, ideally, in the ideal scenario, she would be intubated in the field, IVs placed, and her stabilized. And then oftentimes our life flight teams do have mannitol on board, or they are able to give it occasionally. Hypertonic saline, not so much, but in an ideal world, she would have been intubated. Some access would have been obtained prior to getting on the chopper and then given some mannitol. However, none of that was done. And I think that contributed to the fact that she presented to us fixed and dilated bilaterally. And I think the other question is oftentimes, I think we are more aggressive within the pediatric realm because these children are so young, and they can oftentimes rebound in terms of they're incredible. If you've seen a 70-year-old with this sort of exam, this sort of exam and image, you may say, this is non-survivable. And the question is, what is survivable and what is a good quality of life, really? But in children, they tend to surprise us, and we are a bit more aggressive with decompressing them and treating these large lesions when they do present, even fixed and dilated bilaterally.
Thank you, Dr. Niazi. I'm just going to go through the other panelists for their
Sure.
comments, if you don't mind. Dr. Supa, would you like to make some comments?
Nothing more to add. Thank you.
Thank you, Dr. Supa. Dr. Antrak, would you like to add something?
Yeah, so in this case, it looks pretty classical for increased intracranial pressure. The one thing that I was concerned about in an adult, even before the CAT scan, I believe we would have given, on advice of what the neurosurgeons tell us, we would have given 1 gram per kilogram of mannitol before the CT scan. And so I don't know if it's because it's a teenager that's the reason for the difference. And I guess based on your description, fixed and dilated, I suppose that's better than a blown pupil on the right side, and the lack of other localizing signs. So I suppose that might be an indication, a better prognostic sign that she hadn't yet herniated as a result of the shift and the increased intracranial pressure. But after seeing the CT scan, I would imagine she needs to proceed urgently to the operating room to decompress the right side of the brain.
Absolutely. So she was given mannitol. I think everything went very fast, and she was given mannitol as we were going into the CT scanner, and it was completed. She's about 70 kilo, 14-year-old. So it was completed as we came out of the CT scanner. As the mannitol had a couple of minutes to take effect, her pupils did come down, with the right side staying slightly larger than the left, and anisocuric. And that was another push as to, so we went directly from the CT scanner to the operating room with this young girl. So
Second, Dr. Niazi, I'm sorry. I'm just going to go over to Dr. Epstein as well to see if he has any
Sure, of course.
Certainly nothing to add, but a question. Could you contrast this to the initial treatment, for instance, of a 4-year-old or 5-year-old with the same CT, as opposed to a 14-year-old who's 70 kilo?
Sure. So we would have done the same exact thing. The only concern that we would have in a 4-year-old by giving 1 gram per kilo of mannitol if they do become hypovolemic. And in that case, sometimes if their blood pressure is not stable, then we do give hypertonic saline, depending on what institution you're at and what tertiary care center has available. Some places have just available 3% hypertonic saline, and others have 23% hypertonic saline. But generally, as long as the child is not having some blood pressure issues, I do prefer mannitol, especially if we're going to be going to the operating room. There is a rebound effect with the mannitol, as well as hypovolemia that ensues. And so for that reason, I think it's really important that, especially in a 4-year-old whose blood volume is much less than a 70 kilo 14-year-old, that we really take that into account so that we don't put ourselves kind of behind the 8 ball after this mannitol infusion and run into hypovolemic shock, for example, as a result of the mannitol. So that's definitely something that needs to be thought through in children who are much smaller and less weight.
Thank you, Dr. Niazi. I think you can continue. We've gone through the panelists.
Sure. So as I stated, we proceeded ahead with a right-sided hemicraniectomy, and then also proceeded ahead with placement of an external ventricular drain in the same setting through that right side. And the reason that we do that is mainly for although we are decompressing and taking the bone off, this allows us twofold in order to be able to drain the cerebrospinal fluid and actually treat elevated intracranial pressure, even despite having performed a decompressive hemicraniectomy. These children, specifically children, have significant cerebral edema due to the sheer amount of they lack that brain atrophy that older adults will have in this situation. So they tend to have worsened post injury edema and cerebral edema associated with it. So if we can get an external ventricular drain, we absolutely try to do so. Obviously, if an external ventricular drain is not able to be performed, either because the ventricles aren't hittable because they're slit-like, then we would proceed ahead to placement of a intracranial pressure monitor, such as a bolt. And I'll discuss that here in a minute. So a couple of the herniation syndromes here, she did have uncal herniation, which would be around this area. She also had subfalcine herniation as well. However, she did not have tonsillar herniation. So the uncal herniation is what leads to that blown pupil per se that we were talking about previously. It causes that nerve to be compressed, and it causes that nerve to be, as a result, dilated. There's also associated posterior cerebral artery injury that occurs with this uncal herniation. With subfalcine herniation, you get anterior cerebral artery injury. And she did not have the transtentorial herniation or the cerebellar tonsillar herniation. So this is a good example of the subfalcine herniation here across the falx cerebri here. This is a picture of an epidural hematoma. As this mass effect causes the shift, you get obstruction of the cerebrospinal fluid pathways, specifically of the foramen of Monroe on this side, which then causes a trapped ventricular system on the opposite side. And then here is a nice depiction of this uncal herniation with the associated third nerve palsy that would occur afterwards. So the next steps, again, we did an emergent decompressive right-sided hemicraniectomy and placement of an ICP monitor, an external ventricular drain and bolt. This mannitol 1 gram per kg push was already done. Hypertonic saline again, and in those children, especially young children, if you're hypovolemic or blood pressure is already not sustaining, oftentimes you won't see such a impressive Cushing's triad in those children who are herniating who are younger. And again, Cushing's triad is bradycardia hypertension in the setting of a mass lesion causing herniation. And then we always perform a postoperative CT scan. Oftentimes, these children can blossom other hematomas on the opposite side. So at least in my practice and that of our program here, we almost always perform a postoperative CT scan. Once we leave the operating room, we get a postoperative CT scan, ensure that everything is at least looking better than it was prior to surgery, and then we proceed up to the pediatric intensive care unit. So this is the post-op brain scan that she had. One of the things that I've included in my practice is we do place a silastic sheet over this right side, and what that does is it prevents the underlying or the overlying skin from attaching to the brain, and it's much easier to replace the bone over time. And so that's generally been my practice. It is very, it's very nice when you go back in. So this hyperdense area here is really that silastic sheet and not bone. Here's our external ventricular drain that was placed, and you can see that the shift is improved. However, there is still approximately about half a centimeter of shift from right to left here in this young girl. So this is a good depiction of what an external ventricular drain is, and just to go through this, it's a drain that goes into the ventricles or the fluid spaces of the brain, and then we level it at a certain level. So generally, we will level it at the level of the ear, and then in trauma cases specifically, we'll go up to 10 or 15. What that means is that the pressure in the brain has to get at least over 15 in order for this to drain. If it's at 10 above the ear, the pressure has to get at least above 10 in the brain in order for it to drain. In these trauma kids, anything over 15 is really too high. I know in the adult population, they're a bit more lenient and allow it to go up to 20. I'll touch upon what normal intracranial pressure is in children and adolescents. So this is the preferred method to also measure the pressure in the brain, as well as to be able to treat the pressure in the brain if the decompressive hemicraniectomy is not doing so effectively. And oftentimes it won't, especially as we get to the maximal brain swelling, which is about 72 hours after injury. This is a good example of what an intracranial pressure monitor or Camino bolt is. This is it's exactly what it sounds like. It's a bolt that screws into the skull, and then you puncture the dura, and you pass this this monitor into the parenchyma. This is not. It's a great method to determine what the pressure is. However, you can't treat the pressure once this is in. This we place if we're unable to, again, hit those fluid spaces of the brain, but then we'd have to use other mechanisms and means to help decrease the pressure if the decompressive hemicraniectomy alone is not sufficient to do so. So what's next here? So really, the most important thing after an injury like this is to preserve oxygen and blood flow to the brain, prevent elevated intracranial pressure and further herniation. And really, it's to prevent secondary injury. So in these kids, if the CT scan looks okay and they came in with such a poor neurological scan or neurological exam on admission through our trauma room, I think it's important that we just let them put them down for a bit to prevent any of the secondary injury from too much stimulation, etc. So some of the non-pharmacological interventions that we do is we do put the head of bed to 30 degrees in the head midline. This young girl had a CT scan that was negative, but that doesn't mean that her spine is cleared. But because we typically paralyze and sedate these children, we can just leave the back of that collar on and put her head midline. And then sometimes, depending on what organization you're at, they may do sandbags on either side, but just something to keep in mind. We definitely try to decrease the stimulation. So although all the family wants to come in and everybody is very eager to come into the room, it's important that less stimulation, less sound, low light, all of these things are important. Once we give that initial mannitol, we try not to give mannitol more than that one emergent period of time. At that point, we really try to do hypertonic saline, and we push the sodiums up to about up as high as 155 to 160 if we continue to have problems with the pressures. We give sedation. We also give anticonvulsants. The literature shows that children and adults are at highest risk for seizures within 7 days after injury. Absolutely, if you have this sort of mass lesion and that degree of shift and herniation that we saw, the subfalcine and the uncle with the associated exam that she had, we absolutely leave anticonvulsants on even for longer than 7 days, because these children typically tend to be in our ICU for much longer than that. And again, paralytics and sedation. And we already discussed the decompressive hemicraniectomy and the bolts and the ventriculostomy. So this is a really complex scan, and we're not going to go through this, but it just gives you the general kind of management of children who present, children and adults. This is specifically for children, of those children who present with a GCS score less than 8 and the typical pathways that you would go. We've already hit a lot of these pathways, specifically the decompressive hemicraniectomy, as well as the placement of an external ventricular drain. And then there's different tiers of therapies, and we'll touch upon that very quickly. So critical pathways for treatment of intracranial hypertension, again, you don't want to hyperventilate here. This is kind of the old thought process. And so we'll go through why hyperventilation and some of these things that were done previously are not the norm. And then repeating mannitol is also not the norm. So this was the old critical pathway for treatment of this intracranial hypertension, which some people still abide by, but this is not what is ideal and contributes to that secondary injury. So specifically, intracranial pressure versus cerebral perfusion pressure. It's really important that cerebral perfusion pressure is maintained really greater than 50 in children. And then in this child, I would say even closer to 60 because she's 70 kilos. So CPP is really the mean arterial pressure minus the intracranial pressure. And normal values in adults should be greater than 60. And in a normal state, cerebral blood flow remains constant by autoregulation, and autoregulation is disrupted by trauma. Normal values in children, the minimal cerebral perfusion pressure suggestions in infants and toddlers, we don't have to push up to 60, greater than 40 in children, I would say up to 12, we say up about 50, and really about 16 and older, we say about 60. And this young girl, we did try to push for closer to 60 just because of her weight and the degree of injury she had. So then what are the normal values of intracranial pressure? In adults and older children, really anything greater than 15, unless you're straining, coughing, having these sorts of events, they typically don't tend to be greater than 15. In young children, they typically don't tend to be greater than 3 to 7. And what do I mean by young children? Those children that are about 2 to 8 or so. And in term infants, really no higher than 6 or 7, and that open fontanelle prevents the pressures from getting too high. So CPP is again MAP minus ICP. So the brain needs about 40 to 53 per 100 mLs, 100 grams per minute of cerebral blood flow. So what happens with increased ICP is you have a traumatic elevation of intracranial pressure. It peaks 24 to 48 hours, and cerebral blood flow is affected. And then you also get this hypoxemic, ischemic kind of downstream effects from the associated compression of that posterior cerebral artery, as well as the anterior cerebral artery that occurs from the subfalcine herniation and the uncal herniation. And this peaks about 48 to 72 hours, and this increases the cerebral blood flow. So you typically will get poor outcomes if neonatal CPP, pardon, that's a typo there, CPP is less than 30, and if pediatric CPP is less than 40. And in adults, less than 60, you'll have worsened outcomes secondary to that secondary injury from hypoxic ischemic events that you see. So again, we've gone through these first tier and second tier and then third tier. So we started with the third tier because this child was so sick. And then we're kind of going back and starting again when she gets into the ICU with that first tier treatment with the ICP monitors and the sedation, narcotics, paralytics, and head position. And again, these are those normal ICP values, and then the elevated ICP values. And again, may not show for 24 to 72 hours, and the max swelling occurs at that 72-hour window. So also, it's important that there's really good nursing care, because that can also contribute to preventing secondary injury. So suctioning and positioning. We'll touch upon temperature control, as well as it's important that their hematocrit and hemoglobin stay normal in these children. To control cerebral edema and maintain CPP, it's that respiratory management, blood pressure, making sure that they're not seizing, fluid control so they're not fluid overloaded, because that can oftentimes happen as you're ramping up the 3% sodium, you're not tailoring down the other IV fluids. And then the other question is, at what point do you go to barbiturate coma? And we'll talk and touch upon that as well. So there is a potential for SI-ADH whenever you have a traumatic brain injury. So it's the where you watch for decreased urine output as well as decreased sodium within the bloodstream. And it's something that we really need to just make sure to follow. And obviously, if these children go into diabetes insipidus, that is a very bad prognostic sign. For these children, if they're dumping fluid, and that typically tells you that it's probably not going to be a survivable injury. So hyperventilation typically should be avoided in the absence of increased intracranial pressure, but it really should be avoided in elevated intracranial pressure as well. PaCO2 less than 35, it can compromise cerebral perfusion during a time when cerebral blood flow is reduced for all the reasons that we discussed previously. There are some people that use it for brief periods. For example, if they're trying to palliate until they can get the hypertonic saline, we don't recommend that. And the venous blood sampling that is done showed that this is pretty deleterious to these patients over time. And essentially, this is kind of a Hail Mary. If you are doing these brief periods of hyperventilation, it typically means these ICPs are very out of control, brain is very swollen, and not responding to much else, which again is a bad prognostic indicator. So this was, it's a study from a very long time ago, but it's a good study that demonstrates the adverse effects of prolonged hyperventilation in patients with severe head injury. And it shows that this randomized prospective clinical trial to study the effect of hyperventilation compared to normal ventilation in patients with similar severe head injury. Again, this isn't in children, this is in adults. And significantly fewer patients made a good recovery at 3 and 6 months post-injury in the hyperventilation group. And prophylactic use of sustained hyperventilation has been contraindicated from as far back dating to 1991. However, some centers are still doing it just because of the lack of this kind of understanding, especially if they don't have a neurosurgeon immediately available to kind of help manage, or if it's not a level 1 trauma center or tertiary care center. I'll stop there. I still have some more to go, but I wanted to see if anybody had any questions or thoughts about what I've discussed thus far.
Thank you, Dr. Niazi. Dr. Antrek, you raised your hand in the middle. Did you have a question?
Oh, I'm sorry, I didn't see that.
No problem. I was just curious about the craniectomy. So you and also what the neurosurgeon says, it needs to be very large, otherwise you can localized herniation of the brain through. So, and then what do you do with the dura, and where do you place the that was a Dacron, that patch? Is it deep to the dura or superficial to the dura?
Sure. So when we do a very large hemicraniectomy, so at least approximately about 10 centimeters, so the entire side. And this picture that I showed you probably isn't as good because of that hyper dense material of the silastic sheet. So it's not really showing you the full extent of the hemicranie. Once we take the bone off and do a large hemicraniectomy, we try, depending on who the surgeon is, I try not to go over the sagittal sinus, because you get into that, I think you're getting into a lot and you can avoid that. We then open the dura kind of in a C-shaped fashion and then stellate throughout. And then it's essentially filleting the dura open and allowing the brain to come out. Once we open the dura, we have a couple of minutes and you have to work very fast at that point to start closing, because the brain mushrooms out at you so quickly that sometimes if you don't work hard and fast enough, you can't close the skin. So once you open the dura, our team knows that we're going to be closing about 5 to 7 minutes after we open dura. It's a silastic sheet. That silastic sheet is something that the cardiac surgeons use, as well as the pediatric surgeons. And it's a sterilized silastic sheet. Some places use Gore-Tex, some places use nothing, and they just use this material called DuraGen. I personally like to use something over lying that area, because as you fillet open the dura, the brain mushrooms out and the dura is very far apart. And to allow that brain to continue to mushroom out, we just place that silastic sheet directly on the brain. And then we sew it to maybe 2 areas so that it won't move. And then we go ahead and proceed ahead with a 2-layer closure with the galea and then the skin. And we always leave a drain afterwards as well. But generally so if you don't have a silastic sheet, and again, this isn't the standard practice for all neurosurgeons, But if you don't have a silastic sheet, we use this other material. It's called Duragen, which is kind of a engineered dural matrix that we place on top of the brain that will prevent too much sticking of the brain to the underlying tissue or the overlying tissue. But what happens is if you wait 3 months, which is typically the time period for when we go back in to put the bone back on, everything is very stuck, and these kids can develop seizures afterwards. So I like that silastic sheet. So you just lift it up and it's really nice layer. We send the bone to a bone bank. In trauma instances, for example, if you're the military sometimes would put it in the abdomen. That doesn't really happen here in the States. We send it to a bone bank, and then the bone bank irradiates it and tests it before we get it back to make sure it's not infected. So what they do is they sterilize it, they irradiate it, and then they swab it before they send it back to us, and then they sterilize it, and then it's ready for us to put back in. Yes.
Yes, Dr. Amtrak.
Yes. Well, yeah. One follow-up question. So, and then the drain, I assume it's what, a flat Jackson Pratt drain? Does it go between the silastic and the cerebrum? Or
I put the drain between the silastic and the overlying musculocutaneous flap of the scalp. So we don't put it directly on the brain because if it is directly on the brain, then you're going to have really angry brain come out at you through that GP. And then at the same time, if we can, because the brain is open and everything is open, if we can pass an external ventricular drain, we will try to do that so that we don't traumatize the good side of the brain. And so that we don't have to go and now do an external ventricular drain on the opposite side. So if we can, with the bone removed, and sometimes if you have enough time, where if the brain isn't coming out at you too aggressively, you can bring the ultrasound machine in and see where the how big the ventricles are and hit that that right-sided lateral ventricle to place that externalized drain.
Thank you, Dr. Niazi.
Sure.
Do you have any other comments to make? Okay. Dr. Epstein, would you like to make any comments?
Just a brief comment. 2 large bore IVs were placed in the ER. I think you have to make sure that the nurses control the IVs. I've found over many years that sometimes the IVs are running a little faster than you really want with large bore IVs.
I agree completely. I think that is definitely something where, especially in these young kids, we'll have these kids completely fluid overloaded after any sort of intervention because things are just flowing too quickly. And then as a result, we have too much fluid in the lungs, and then that contributes to the hypoxemia and all of the other problems that we have. So absolutely, I think specifically in these younger children, it's really important to monitor the fluids going in to prevent the secondary injury that will ensue from fluid overload.
Thank you, Dr. Niazi. Dr. Supa, would you like to make any comments?
I'd like to ask about the role of therapeutic hypothermia. I saw something about that in the slide, but you didn't mention that.
It's, I'm gonna, no, absolutely. Actually, I'm gonna get to it right now. There's some, it's controversial, specifically in children. So I'm gonna get to, I have 2 slides dedicated to that. So we've already discussed the mannitol, and what we do is I tell my residents, if you give 0.25 grams per kilogram, it's like spitting in the ocean. You are Here, you're only giving mannitol because this child is herniating, the pupils are dilated, they have impending uncal herniation, and 0.25 grams per kilo is not what we want at that point. We want to go big or we want to go home, essentially. So you want to give as big of a dose, and you want to be able to give it as quickly as possible, as long as the blood pressure will tolerate it. And again, you use this until the serum osmolality is about 320. We touched upon this previously, that the hypertonic saline, it can effectively lower the ICP without causing hypovolemia. And we typically tend to increase the sodium level up to 160. Some people go up to 170. I don't like going up that high. I think 160 is more than enough to give us the effect that we need to help. Barbiturate therapy is another thing. So let's say you do the decompressive hemicraniectomy, you put the externalized ventricular drain in, you sedate them, you paralyze them, you elevate their ICP, I'm sorry, their sodiums, and you've done everything that you possibly can, and the pressures are still 30, 40. That is going to portend a worse prognosis for you. But if the parents, which generally the parents want everything done, and the child clearly isn't brain dead, we proceed ahead to barbiturate therapy. In the adult population, this group typically tends to have a worse overall prognosis. In the children, I would say it's probably the same as well, but not studied as extensively as in children. And again, this is only when we only use it as a last resort. It's kind of our last Hail Mary in our pocket.
Dr. Niazi,
all right, here we, sorry, go ahead.
You. I'm so sorry to interrupt you, but I'm just going to ask Dr. Kasim if he has any comments before you proceed.
Okay, I'm sorry.
No problem. Dr. Kasim, we can't hear you.
So of all the herniations that you have mentioned, and I learned a lot from that, which of these herniation actually kills the patient?
So really it's the uncal herniation and then the Duret hemorrhages from in the brainstem that really cause the biggest problem in these children. I think, you know, that's, and really the question is we can typically salvage these children, but how functional are they going to be? And in parents, their faith is much higher than in adults. I think that parents tend to push and they're always optimistic. And I personally have been very, you see a scan that's very impressive. And I'll show you this young girl's scan, her MRI. And then you see them 6 months to a year later, and they're definitely not the person they were before, but some of them can be somewhat functional, specifically if this was affecting more the right side of the brain than the left. So speech is at least somewhat saved, but they definitely have limitations and handicaps throughout the rest of their life.
Is the quality of life an issue here?
You know, I have to tell you that these parents are amazing. And I can tell you that I've never had a single parent tell me that they want to withdraw care. And I think quality of life absolutely is an issue, but these parents are not willing to let go of their children. And because they're not brain dead, we have to continue to move forward. And really in the United States now, even in children who are brain dead, it's become incredibly difficult to withdraw care on those children as well, given some of the recent kind of cases that were taken to court and children who were presumed brain dead and other institutions had taken over their care. So it's become kind of a messy situation in children who are brain dead. But in these children who aren't, they definitely have limitations, and the parents are not willing to give up.
Not surprising because nobody dies in Florida, right?
Exactly. Exactly. So this is now to your question about hypothermia. So hypothermia has really been it's very controversial. So back all the way in 2005, there was a phase 2 clinical trial of moderate hypothermia after severe traumatic brain injury in kids. And so what they found is that in patients with GCS less than 8, moderate hypothermia, they had reduction in mean ICP during the first 72 hours. And however, rebound ICP increases observed with rewarming. So, I'm sorry. So the trend towards lower mortality and better functional outcome at 3 to 6 months. However, this wasn't statistically significant. There's this trial called the Cool Kids study, and it was kind of shut down early because it wasn't found to be statistically significant and because of this rebound intracranial pressure. Now, most recently in the neurocritical care, updating evidence for using hypothermia and pediatric severe traumatic brain injury, looking at this meta-analytic perspectives, and there are trials going on at Boston Children's and several other places where they essentially, there's no difference between hypothermia versus normothermia on mortality and poor outcome, but it really couldn't be rejected. And so what I'm trying to tell you is that when it's the last option, if we continue to have elevated intracranial pressures without any improvement, prior to putting them on a barbiturate coma, we will cool them. Again, it's kind of the last, some of the last tools that we have in our toolbox before we proceed ahead with that barbiturate coma. But it's definitely not used across the board in pediatrics. It depends what institution you're at. And it is controversial because some centers will say this hasn't been found to be statistically significant, the rebound and intracranial pressure on rewarming, it's not worth it. And I think it's a case-by-case basis and an institutional basis as to whether or not you're going to use it. And even amongst the neurosurgeons, pediatric neurosurgeons within one institution, you may see variations in how this is used. So it's not a, it's not as well studied as, for example, hypothermia after cardiac arrest, but it has been used, but not validated as the thing to do in children. I'll stop there for any questions as well.
Dr. Niazi. Dr. Amtrak, would you like to make any comments? We can't hear you, doctor.
Nothing to add, thank you.
Sure. Dr. Kasim, would you like to add something?
Nothing to add. Nothing to add. Thank you. And I've learned a lot. I'm glad I got up at 5.
Thank you for joining us.
Thank you, Dr. Kasim. Dr. Epstein, would you like to add something?
Absolutely not. It's fantastic talk.
All right. And Dr. Supa, would you like to add anything?
So I just have a couple of more slides. I know that I'm running out of time. So just a couple of other things. Steroids have not been, they're not recommended to be used in the setting of trauma. And it's not recommended for improving outcome or reducing intracranial pressure in patients with severe head injury. And so it's generally not something that I use. We did touch base upon this anti-seizure prophylaxis, the AEDs. In these kids who've had surgery, I do place them on AEDs for greater than 7 days. And now we're using Keppra. Things have definitely evolved since the 1990s, but the whole point of the reason why I'm using this study from back then is because it was in the New England Journal of Medicine. It was a landmark paper at that time. And it was something that was, very important to prevent this, seizures and elevation of intracranial pressure during that time. Nutrition is the other really important thing in these kids. So these kiddos and adults, so recommendations from the Brain Trauma Foundation, it's important to replace 140% of resting metabolic expenditure in non-paralyzed patients. But in children, we will do it in paralyzed patients as well, as long as things are moving, but up to 100%. And obviously, if they are on a barbiturate coma, then we have to be very careful with that, because then not only does the barbiturate put their brain to sleep, but it also puts their belly to sleep. And then you can end up with a ileus and some not so great things from the bowels, which we tried to prevent. And so this is just a paper that discusses the favorable effect of early parenteral feeding on survival in head injured patients. And I'm going to skip through that. And I just wanted to show you her scan. This is her MRI. We do an MRI after a couple of days. I would say once we get through that max period where the swelling is the maximal amount, we do try to do an MRI. If we can do it within 72 hours, if the intracranial pressures are able to be tolerated, then we will. That way we can also clear the spine and do a quick C-spine stir and make sure that there's no ligamentous injury there, so that we can take that collar off and have to not worry so much about the neck moving around, but that has to be done within 72 hours. So this is her scan, pretty significant injury. I think there's definitely some, looks like PCA infarct here. From the uncal herniation. She also has anterior cerebral artery infarct that has occurred here from the overall subfalcine herniation that occurred. Here's the uncal herniation that's caused cerebral peduncle, injury and diffusion restriction, which is pretty classic for this uncal herniation. And then this typically, this kind of distribution is not typical for these herniation syndromes, but it tells you that she was hypoxemic at some point after this injury, which goes back to the comment from the beginning of how this was managed in the field. And she should have been intubated in the field. And it's something that we need to work on better with whoever is the first responder and who's scooping them up and bringing them in, is to make sure they have the ability to be able to intubate, because some of this injury is a result of the hypoxemia as well. This is injury across the corpus callosum, which is consistent with diffuse axonal injury. And then she does have some injury in the deep basal ganglia. So I would say, to the question of what is the quality of life of this child, I think it's going to be a long uphill battle, but it's really hard to get these parents to say that they don't have faith. And you're surprised more often than not when you see some of these kids coming back to your clinic, looking at the degree of injury they have and how they look after several months to a year. So thank you very much. I think that's all I have, and I'm up, my time is up too. So I appreciate all of your time today.
Thank you, Dr. Niazi. I just want to go over and just ask if anybody has any final comments. Dr. Andrzej?
So a question on this MRI, the two slices, are they at the same time or different times, or?
They're at the same time. So they're just slices. I just picked two sequential slices. So it's the same time. The one on the left is a lower scan. And I wanted to show this one because I wanted to show that uncal herniation that compresses that cerebral peduncle in the midbrain. And then this is a slightly more superior cut that's showing you kind of the anterior cerebral artery distribution, the diffuse axonal injury across the corpus callosum. And then this other injury, which typically is secondary to the hypoxemia that occurred more so.
And follow up, how far is this girl out from her injury?
So she's about 9 months out from her injury. She did not require a shunt. Sometimes these children develop hydrocephalus. Her bone went back on. She is hemiplegic and not moving that left side, but she is talking. So she's getting therapies and can't walk independently, but is still in there.
And one final question: was she wearing a helmet? I've never gone parasailing, and I don't. After saying this, I don't intend to. But is it routine for people doing this to wear helmets? And was she wearing one?
She wasn't wearing a helmet.
Difference? Yeah,
she wasn't wearing a helmet, and I think that's one of the things here. You know, you have to sign your life away when you do any of these activities here. Especially down south. And typically they do recommend a helmet, but they don't force you to wear a helmet, and you sign your life away on the dotted line. So really at that point, it's not their problem if you wear a helmet or not. And really this child should never have been on a parasail that day because the winds had picked up. There was a storm coming in, and when the winds picked up, it kind of blew their parasail. And instead of the boat, so the way the parasail is attached to the boat. And so if the wind picks up and the parasail moves up, it will lift the boat up too. So this gentleman just cut the line of the parasail and let them kind of go. So that the boat, and her mom didn't survive. So it was her and her mom did not survive the injury. So.
Oh, very sad.
Yeah. I think it gives us all a different perspective when we want to go to tropical places and do fun things, especially when you have to sign away your life on a dotted line. At least this was in the United States, but we do see several injuries from the islands that come over to us that are in line with this as well.
Yeah, but this is very simple, right? Sometimes you go to these places and you think about security. Some of these places, they don't have good standards of security or safety or checking the weather, etc. At the end, it's up to us. It's our lives, our family members. Like 1 second, everything can change, and we need to be aware about that, right?
100%, 100%. I think it's definitely something to think about when you are, anytime you're having to sign on the dotted line that this could result in death or injury, to really think about what it is you're doing. And I think it gives me great pause when you're in a country outside of the United States doing it as well. It gives me great pause because who's going to take care of you at that point? And then travel insurance and all of these other things that come into play, which we deal with a lot of these kids. It's horrific.
Yeah. So outside, sometimes the insurance doesn't cover, the trauma system doesn't exist, and everything became a disaster. So once something bad happened, right? And again, it's eye-opening for everybody.
Absolutely. A nice fun day parasailing ends up like this. Not something you would expect.
Yeah.
I do these things a lot, and I think it made me think twice before having to sign on that dotted line.
Yeah. I guess just make sure that there isn't a big storm system coming in, right? Because these things are expensive and it's a business for them. And they just try to get you in and out. It's a business and keep going. But when push comes to shove, those guys are always going to choose themselves over you. So the fact that he cut the line, I don't know what happened with that. But the fact that the line was cut is, it's eye-opening.
And you're right. Like I did go parasailing once, and they never forced me to wear a helmet or anything.
Exactly.
It's and they're like, if you want to, you can, but they don't restrict it.
Exactly.
Thank you, Dr. Niazi. Does anybody have any other comments? Anything that anybody wants to share?
Just a quick comment. What happens, we see these miracles on TV, and I don't think it helps us in the trauma center.
I agree with you. I completely agree with you. I tell, as neurosurgeons, we say, and I'm sure as you guys as trauma surgeons, there's a fate worse than death sometimes. And, you know, to have a child who's completely neurologically devastated and dependent on all care, you know, it's really a fate worse than death sometimes, because they're never going to be your child again. And now you have to worry about who's going to take care of this child if something happens to you as you get older. So absolutely.
Thank you so much, Dr. Niazi, for this very extremely interesting case and a very good learning experience. I did learn a lot from the case. So thank you so much for presenting, and thank you everybody for attending. I'll hopefully see you all next Monday.
Thank you all.
Yeah, so thank you very much. Remember, everybody, it's very important to have diverse case. That was a very important case with neurotrauma. Please join us again, Dr. Niazi. I'm looking forward to have your expertise again. And everybody, please remember, in November, they're going to have the Pan American Trauma Society Congress in Cartagena from November 1st to 4th. You're all invited to join us over there. You're going to have a great meeting. And please contact Valeria and Maya and Patricia to book your presentation for the next few weeks. And again, this meeting, we reached the number 500 of these meetings. We did more than 500 meetings in the last 12 years. So again, a lot of learning, a lot of teaching everywhere have been happening here for 12 years. Thank you very much, Dr. Niazi. Looking forward to see you again and see you all next week. Bye.
Thank you so much.